Sorry about that. Thank you.
No worries. So really just wanted to kind of share a little bit about how we got to where we are, I guess, and kind of how we do the work that we do. Similar to the PMHCA programs, the EMSC Innovation and Improvement Center is funded through HRSA, so Health Resources and Services Administration. And really the work is to grow health services to improve outcomes for children, more specifically, similar to PMHCA's. So there's, lots of opportunity for alignment. Much of the work for EMSC has been over, the last 40 years has been focused on both the ED and pre-hospital care space. Sorry, I'll get to this in a second. You can leave the slide here. But it's really been focusing on enhancing our system capacity within this space. The initial program, it's really, a baby program that's housed within the Maternal and Child Health Bureau under the EMS for Children program, is focused on enhancing systems through 5 different arms of investments. So these are really the 5 investments. It started in the mid-1980s when we received initial authorization. And fortunately, because of the work that's happened, has continued to grow. I think what was interesting for me in being able to be part of EMS for Children was learning a little bit about the history of how our emergency care systems developed. And I'm not trying to talk at you, Lauren, so feel free to interject if you have any thoughts, ideas, comments. But it was that our emergency care systems were not designed with kids in mind. And in fact, most of the early work in our emergency care systems were focused on, broad level trauma and all the accidents that were happening on highways and motor vehicle safety, but really not specific to children, which I'm sure you realize since car seats have only recently become a mainstream requirement. Also focused on really stroke care because they were seeing the massive financial costs to patients around the country, and then heart work. So heart attacks, heart centers, interventions to really improve those. And so all of that work started in the mid-60s, and there was nothing really focused on kids. And so when I think about the EMS for Children program, it's really the singular program, the singular federally funded program that's really has at its primary goal of bringing children into the emergency care space and really growing their voice and their needs. And so all of the work within the EMS for Children program is designed to do that, is to enhance the systems to meet the needs of children. The EMSC Innovation and Improvement Center is really the national resource center that serves as the primary glue and communications arm for all of the investments. That's where Dr. Charles Macias and I co-direct, based out of University Hospitals Rainbow and UT Del Med in Austin, which is where I'm housed. And we do a lot of work through, a big website. We develop resources and educational products. We provide a number of quality improvement collaborative opportunities so that frontline healthcare providers can kind of take an initial first step into the space of how do we enhance our systems locally. And we use measurement. So we use a lot of integration of analytics, but we're really founded in quality improvement methodology because we know that quality improvement is really the best, most efficient mechanism to transform healthcare systems. It's been shown in the literature. And so that's, really where we emphasize our work. We have a sister center called the EMSC Data Center, which is actually housed in the University of Utah, and they are more specifically focused on measuring the current state of our emergency care systems. They lead a lot of national assessments, looking at the readiness of EMS agencies and EDs to meet the needs of children. There are targeted issues grants, which are like systems innovation grants, trying to design new technologies, new protocols, new ideas for approaching the problem. There's a PCARN, or Pediatric Emergency Care Applied Research Network, which is a network of 18 children's hospitals. These are high volume centers. Most of them see probably 60,000 kids a year plus. And because of that, they're able to develop evidence-based practice guidelines for high-risk conditions in children. And then the state partnership programs are probably the ones that are most aligned with the work of PMHCAs, because their focus is really within an individual state or US territory. And they are trying to figure out ways to integrate and formalize and sustain pediatric infrastructure within our emergency care systems. So we at the EMSC Innovation Improvement Center are charged with supporting all of these investments, while also accelerating the work through communications, through measurement, and through launching quality improvement collaboratives. And I think, within, as you know, within the emergency care system, the call to action, the U.S. Attorney General, everyone kind of speaking to the needs of children when it relates to the mental health care space. There's also been a growing awareness of the impact within emergency care systems as the safety net for children. And we've obviously experienced that strain firsthand. For many of us, we've witnessed that strain nationally. We've heard about it through our partners and through our frontline healthcare providers. And it provided a natural bridge, I think, for us to work with the PMHCA awardees to begin to figure out ways to solve or address the challenges that kids are facing. So I know that's a very long-winded overview, but hopefully that gives you a sense of kind of how EMSC got into the space of trying to work with PMHCA programs. Any thoughts about that or comments from any? Or Lauren, did that give you maybe more of an overview than you were seeking?
Still absorbing. I don't, you know what, I'd rather hear it than not, because then it'll be like the third time and be like, oh, that's what they were talking about. So it was definitely a good overview. It definitely sounds like you guys are busy.
Yeah, but I think mental health is something that's so near and dear to our heart. And sadly, I think even within the work that has happened within the EMS for Children program, there's been so much focus on trauma and medical, and it's only been this recent, awakening around mental health crisis that we've turned a lot more attention to it. Our first effort around this was actually, you mentioned being in the role of policy now. About 3 years ago, we worked with about 8 states around the country to look at how to develop telehealth programs to address either children with mental and behavioral health emergencies or children with special health care needs because of other types of chronic conditions. Many focused on mental health emergencies and care, and really began to look at what are the ways that we can implement telehealth programs, what are the needs. And I think there were a lot of lessons learned from that collaborative, but first and foremost are just the complexities of implementing these telehealth programs. And I do think that the way PMHCA awardees have developed programs that are more founded on teleconsultation provides a nice more efficient or straight line model to gather or provide that support without necessarily providing direct patient care, because that was one of the challenges that folks faced. I think the other challenges that people were facing is just related to the technologies that are being used, and there's been a lot of discussion around that. Certainly the medical legal aspects of providing recommendations. But we learned so much from that. And it was a really big kind of conceptual framework to kind of foray into this sphere. But it taught us a lot. And out of that, we had developed some tools and or a toolkit on telehealth that we hope can be used more broadly. But I think through work with PMHCA awardees, it's allowed us to really narrow our focus on the needs of children with mental health emergencies, which is important because telehealth is so big. And this is probably one of the most important areas of focus. And by focusing more on the ED space as opposed to the ED and EMS space, it also kind of makes it a little bit more achievable. And so we're just excited to kind of see where the field is and how we can begin to help support PMHCA awardees in this space. So I know the rest of the work sounds big, but but that's really our goal within the EMSC Innovation Improvement Center, is to provide the resources, the tools, the networking for implementation.
I love it. It's long overdue, that's for sure.
It is long overdue. I mean, I'm sure you've seen this so much being in the field and responding, especially to disaster situations. Were you directly involved during sort of pandemic response and things of that nature, or?
Yeah. Oh gosh, I mean, I feel like everybody was in one way or the other, just working in any type of, position, being in healthcare. But outside of that, I kind of like led just a lot of community efforts to make sure like people could get food, because food pantries and, all these other things that people need, social determinants of health and whatnot. So I was going out in the community a lot compared to other people, which at the time was fine. I was okay with that. And then I also started working at one of our COVID shelters. So that was really interesting. That was a very interesting experience. And because we didn't have a lot, and I mean, New Hampshire is small, but when you're homeless and there's not a lot of options, we got people from all over the state, all different backgrounds, all different needs, and different barriers because they're coming from different places. So that was a lot. And then I had decided to have a baby during a pandemic, and then I started working at the hospital. So working in the hospital and still dealing with COVID, and then COVID completely exacerbated mental health for our kids anyways, and adults, but definitely we see it more with I shouldn't say more, but we see it differently with our kids. The hospitals are just inundated. There's no help, there's no support, and it's constantly treading water.
Well, and it's so hard for these families too. Like if the emergency care system can't support you, where do you turn? And particularly during these more stressful times like COVID and the shelters and yeah, the power outages, the freezes, the heat, I think we're going on 45 days plus over 100 degrees here in Texas. So
oh my gosh,
it's just all these things, right, that we're going to continue to face. And recently we've been talking a lot about mental health and disasters, because another recently funded effort you'll probably hear more from Dr. Macias about is the Pediatric Pandemic Network, which is a sister network to the EMSC program, but focus more on disaster preparedness with everyday efforts, a component of that. But how do we respond to these disaster events related to mental health? And obviously you have experience doing that, so you've started to pave the way in that, you see it. But then how do we think about it from a systems lens where you can deploy the appropriate workforce in a timely way to communities that are often under-resourced and underserved? Welcome, Heidi. We're just having a casual conversation.
Thank you. Good to be here and see what this meeting is about and learn a little bit.
Yeah.
I'm from Wisconsin and new working in this area with the
Oh,
state of
nice.
Wisconsin. So
Very nice. I was just telling Lauren, a few years ago through the MSc Innovation Improvement Center, we had launched some work in telehealth more broadly, not necessarily specific to EDs or there were two arms. One was mental health, one was children with special health care needs. But in Wisconsin, there was actually a lot of work done within the EMSC State Partnership Program, which is one of the other investments of the EMSC program. We provide a lot of support and collaborate with them a lot on how to improve our emergency care systems to meet the needs of children. And Wisconsin has a really robust program. I don't know if you've had any connections with them. Erica Kane is their EMSC State Partnership Program Manager.
I know the name. I haven't met her yet, so I look forward to that. Good to hear.
Yeah, she's wonderful. And they work really closely with a couple of the leading children's hospitals in Wisconsin, not just one, but it's University of Wisconsin-Madison, and then there's another children's hospital. Sorry, I'm forgetting the name, but they work really collaboratively together to improve care for children, and they would probably love to hear about the work you all might have on the horizon. Lauren was sharing a little bit about her background, having done a lot of primary mental health outreach and work in the community. Do you mind just sharing briefly your background, just so I understand it a little bit? Heidi, sorry.
Sorry.
Oh, no.
So yeah, I've worked with the state for a long time, and I'm a health educator and a licensed practical nurse. I've done mostly grant administration, and so I'm stepping into this role as a grant administrator, and which includes the Pediatric Mental Health Care Access Grant. So trying to get my feet under me and learn all the partners and moving parts.
Nice. So within this technical assistance that we're trying to provide to PMHCA programs, we've kind of outlined a few different potential kind of arms of work that have been informed by your PMHCA colleagues, but one really focused on how do we educate our community partners, schools, school nurses, primary care, pediatricians, families about what happens in the ED space when a child comes there for a mental health crisis. What might they expect? How do we educate those families so they're not overwhelmed, shocked, surprised, stressed by the whole experience? We've also talked about, I think, maybe to more your interest, Lauren, is how do we provide teleconsultation to ED providers so that they have a better understanding of perhaps resources that might exist if they were to discharge a patient, because not all EDs have direct linkage to inpatient wards that accept pediatric patients with mental or behavioral health emergencies, and oftentimes they're stressed with we don't know what to do, or they end up just transferring all these children out to children's hospitals where they just end up, further away from their home, boarding for sometimes days, sometimes weeks. So, just how do we provide teleconsultation maybe to help open up ideas or suggestions about disposition and resources and what to do when resources are limited. And then the third arm is more like the direct telemedicine, which I don't know as many PMHCA awardees are quite as interested in taking that piece on. But within the EMS for Children program, we've done a tremendous amount of work in developing educational resources that meet the needs of different persona, and really trying to think about how are the tools in the toolkits used to inform these individuals where they are, whether it's the families or the youth themselves or school nurses, et cetera. But our hope is that through this work, we can help provide some insight into what does happen within the emergency department setting, so that should you choose to embark on this path related to developing educational tools or products to support frontline healthcare providers and understanding the ED space, when to send, how to send, who to send, then that's somewhere where we, I think, could really collaborate and provide some work and support. The other, which is within systems, is that much of the work we do is really about trying to enhance our systems. And I think this teleconsultation piece in EDs is a way of just expanding the resources that exist there. We know that over 80% of children seek care in general emergency departments, the majority of which don't have pediatric inpatient capabilities at all. The majority of which see fewer than 10 children a year. Yeah, thanks for sharing this, Jen. And who really don't know what to do when it comes to critically ill or injured children, and much less children with mental health crises. And I think it's such a work in progress, and this recent uptick in pediatric mental health visits has just put such an enormous strain on these emergency departments. Many of them may have figured out ways to address psychiatric emergencies in adult patients, but the treatments we use for adults aren't necessarily the right treatments for kids. And so, how do we help them in their interim? I love these mobile crisis teams that can come out and provide support. Tell us more about that, Lauren. What are you seeing in New Hampshire?
So I'm going to try to speak, as my coworker would say, not from my wounds, because direct care can be a lot. But so I always think there's room for improvement. The idea of mobile crisis is great, and there has been a lot of success with it. But like I said, there's always room for improvement. But something that we have noticed that has been helpful, especially, at least in the hospital that I was working at, we had one hospital that in occasion we would have to go up there because maybe it wasn't appropriate to do telehealth, but it was really an understanding that we mostly did telehealth because it was like a 45-minute drive. So that seemed to be an understanding just to kind of expedite the process. But if we would see, somebody that we would call a frequent flyer, whether it would be an adult, or a kiddo that was coming in, oftentimes we would be alerted. I mean, we would have access to see who would, check in the ED waiting room. But if we had somebody, another clinician available, we would say, hey, like, mark yourself as unavailable so you don't get dispatched, and go down and start talking to them. And most of the times we would let the doctor know. Sometimes they even call us ahead of time because they want to avoid having to put in an order and do all these labs, everything that would keep them there longer holding a bed, which sounds awful to say, but most of the times it was because, winter or, something else was going on and they needed a place. So oftentimes one of us would go down there and really just try to triage and, hey, let's do a next day appointment. Let's have you come back. Let's have you get connected with navigating recovery. Obviously, sometimes there could be a medical need that they would have to be there for, but there were a lot of times we would try to get ahead of it because we didn't want them waiting in the emergency room if it wasn't the best spot for them, where they would be waiting forever. And, if we could get them to more appropriate care, obviously that was our goal. But mobile crisis still has just always room for improvement. So I think getting more support to the clinicians and a better understanding of, not everybody you meet with is just dealing with depression. Oftentimes there's two different things going on, whether it's substance use, there's homelessness. So there's only so much you can do, but the mobile crisis team was really used as a good way to kind of triage and divert them from coming into the ED, especially if we knew that we did not have a chance for inpatient because they'd been declined maybe so many times.
So was it mostly counseling and de-escalation and coordination of care, or was there also treatment that these mobile crisis teams will sometimes provide, like medical prescriptions and things like that?
So most of the calls, so we do have a provider. However, the provider, and I don't know if this is something that is going to change in New Hampshire, our provider was not able to really have anything to do with mobile crisis, like, which seems odd. You know, we could go to our supervisors. So she could give feedback if we needed to, you know, kind of process or, you know, just kind of reflect and say, what could we have done differently? But as far as the medication piece, we couldn't really have done much there unless we knew, like, hey, you know, let's call your primary care doctor together. We often found a lot of times the calls weren't, we definitely had some true crisis calls where people died. In that, and you don't want to say, wow, that was such a good use of, you know, mobile crisis, but we're like, okay, like that was an effective service. They thought of us, they wanted us out there to support them. So most of the times we found it's just people can't, you know, they're so bogged down with everything else. They can't even manage or, you know, have a clear thought of, okay, my prescription ran out. I need to call my primary care. Like some people, they just don't have that level of functioning. So a lot of times it was helping with that stuff, but we did, and a lot of times our kids, what we would see is the schools wouldn't be able to have a counselor, or they didn't have anybody on site that could provide, you know, an assessment. So they would say, in order for you to come back to school, you have to meet with mobile crisis and get an assessment done. So most of the times we found with the students, it wasn't really the way that I phrased it with them is, you know, and I would talk with my hands and I would say, okay, so you're over here and you say you want to die, you know, die. And I'm very blunt about it, you know, the parents there, and I explained to them, like, I have to be very clear, you know, you want to die, you want to be 6 feet in the ground, you believe in heaven, or, you know, you don't see your parents anymore, your friends, or is it that life is just really freaking hard and you want to be done? And most of the times it was that life was just really hard. So a lot of times it's the students aren't educated, but they're also adolescents, so they don't understand their language that they're using triggers a certain process. So then it kind of impacts the parents and they go, okay, well, now you can't go back to school until we get a letter. It's just it's a whole to do. So there's a lot.
Yeah, that's amazing. So it sounds like in New Hampshire, you already have a way of launching the mobile crisis, like EDs could launch a mobile crisis, or is it more in the community to avoid an ED visit? It may be the latter, huh?
Well, definitely in our North Country where there's one community mental health center that covers, it feels like, way too many towns, but they have to be telehealth because they would be driving like up to the Canadian border. Like it's so far up there. So some of the hospitals, my understanding is they have to use the mobile crisis line, whatever that has looked like. But at least when I was working, the way that it was set up is, you know, let's say all the clinicians from, I think it was Northern Human Services, if all of the clinicians were already dispatched, you know, and they're already doing other evals, they would go to the next available person. So if we're in a whole different town that's an hour away or 5 hours away, they're going to contact us. They're going to keep going until somebody responds. We had the option to go in person where other places don't. So there were times where we were driving, you know, maybe 3 hours one way, and that was a lot, but I don't think they've found a way because not everybody has internet. Not everybody knows how to use telehealth or Zoom, you know, these things. So those were some of the other barriers that we were seeing. But
Well,
I do think it's helped.
Yeah, it's really a nice model that's in some ways aligned with like mobile integrated health units or community paramedicine, where, you know, folks are going out and providing support for like asthma or traumatic brain injury, or, you know, that kind of follow-up, or you know, adults with mental health issues. But it's interesting too, because there's another PMHCA program that's rather than working on the front end, which is what you're talking about, they're working on the back end of child goes to the emergency department, they're discharged, and we're trying to get them into some kind of community-based mental health support system. But we can't find one yet, or we can't get them access to that yet. So they're providing kind of a temporary intervention to children who more or less forced to discharge based on resources and,
So they're getting discharged with no follow-up?
Well, they're getting discharged with follow-up in this temporary support program, almost like
Okay.
a crisis support.
Yep.
Until the follow-up can be obtained, so they can get up to 5 sessions and then, transition into, a long-term mental health support program. So it's a similar kind of temporizing measure, right?
Yes. That's
Which-
what our mobile crisis was doing. I believe they are still doing as well. But the other problem that we were running into is insurance was a real stickler. So even if you felt that somebody, if I met with Jane and I said, yeah, I think you could benefit from a follow-up, but I don't think it necessarily needs to be a clinician, maybe you need a peer support, or maybe you need a case manager. Their insurance dictated that. And, my personal opinion, but insurance people should not be the ones, I think, always making those decisions. That's my tidbit, but I'll stop. So that got really frustrating. And we would say the same thing, you could have very limited appointments, but it's really hard to tell people that when they have nothing, and we can't even triage them, to have an appointment with, maybe they get into their primary care, because they have an integrated care team and there's somebody there, so they're oftentimes still left waiting. We'll do 1 or 2 follow-ups and then they're done. And then we hope that they get somewhere. So, we were seeing the same thing.
Mm-hmm. Yeah, there's so given that both of you are housed at the state level, I do think education is a nice, easy first step, obviously. But as we move beyond education to how do we intervene on our systems of care, before you get to having resources like mobile crisis outreach teams, which is fabulous, is how do we begin to develop standards around what to do, and then also how do we begin to measure the current state or the impact. It's hard sometimes to advocate for services when you don't know, what the current state is, or develop a standard for even evaluating that current state. One of the pieces that came up recently in some of our discussions with other PMHCA awardees is how do we standardize the triage to emergency departments for children who have mental health crises. So we see this a lot in EMS, which is also housed within Department of Human Services or Health Services or the equivalent in states. And most states actually have statewide EMS protocols. And I also happen to be an EMS physician. So this is also kind of my area of work in addition to being a peds emergency medicine physician. But most states have EMS protocols that are statewide protocols for what should, EMS providers be doing in the care of someone who presents with this or that, or what's our treatment protocol, what are our diagnostic approaches, where do we transport them to? And I think from a state level, if you're really looking at that system, that's a real opportunity, is what are the standardized triage tools that will be used? And Lauren, it sounds like you already have this with the mobile crisis team. I don't know if they're using a standard approach to triage all of these patients and developing almost like a protocolized pathway for frontline healthcare providers or for these teams. But it's a really nice first step, is to say, based on the resources that we know exist, let's develop a standard triage, and then let's test that and see if that works in our state, if we're capturing the need or where the need is, and how do we develop a robust system. So moving from education to kind of policy or protocol development is a nice first step in getting towards a more robust response. If you're housed within the state system, it's just kind of a nice potential pathway to beginning to address these problems. But I don't know if you all have thoughts about that. Would love to hear. I think New Hampshire has state EMS protocols. Heidi, are you aware if Wisconsin does?
I don't know that. Yeah, it's a good question.
It's also a nice way of kind of broaching these ideas of like, how do we, you know, adopt a standardized evidence-based tool for how we triage children to the ED or to an alternate service? And you
It'd
know,
be
like,
nice if they do. I mean, that
Yeah.
would definitely be more impactful to if we did have state level protocols.
yeah. I mean, if you do, it's a nice way to kind of leverage that and say, well, maybe we should have them for mental health emergencies too, and how do we develop that? You know, a lot of the work that we do in the ED space for mental health is based on national consensus-based guidelines or joint policy statements, one of which is posted on this slide that just was published this month on how recommendations for managing children who present to EDs with mental health and or behavioral health crises, and what should be the pathway towards treatment. And I think this is okay. Thanks, Lauren. I think this is a interesting. It provides a nice framework for how to approach the problem within the emergency department setting, but it's not always as tangible for PMHCA awardees because the work that you all are doing is more often outside of the ED and maybe touching base with them, but not necessarily being able to transform all of the clinical steps. However, we have been working with a number of ED teams. There's a National Quality Improvement Collaborative that we launched now about 6 months ago, called the ED Stop Suicide Collaborative. STOP stands for Screening and Treatment Options for Pediatric Suicide. And we've been working with these ED-based teams to say, here are some recommendations on how you adopt an evidence-based tool for screening and an evidence-based approach to the full mental health assessment, and whether you should or shouldn't get labs and or other diagnostic testing. How do you support families that are boarding? And then how do you safely discharge these patients so that they have the appropriate and or necessary follow-up after their ED visit. And that's been great because we're trying to kind of raise the field and help support these emergency departments and moving towards evidence-based guidelines that we know are associated with improved outcomes. But many of the PMHCA programs are wondering, where do I intervene in this? That's not where I work. But what we've heard from these ED teams is sometimes the biggest challenges are we can't get access to a pediatric or a licensed mental health professional to provide guidance or support. And in the absence of that, our opportunities or only choices are either transfer the child to some large capacity center or discharge them to home. And so in those kind of in that framework, we've really talked about strategies where we could leverage PMHCA programs and our resources. So just looking at this table, these are recommendations that came out of the evidence-based guideline and joint policy statement. And it's, you know, like telehealth type strategies for consultation. So visual, like digital innovation, virtual innovation strategies to how do we deliver that care that can help expand their internal services and make recommendations either through consultation or direct telemedicine. Really thinking about more robust follow-up programs, whether it's either linking them to outpatient resources, or as I was mentioning earlier, one of the PMHC programs developed this like stopgap intervention for kids who have to be discharged or are appropriate to be discharged, but really need outpatient resources and they're not immediately available. So providing, you know, several mental health counseling sessions in the interim until they can formally move into a long-term follow-up program. And then the last is really trying to educate these teams on some best practices around diagnoses and care and the like. So those are some of the areas that we've really tried to align PMHCA programs with what's happening in EDs. And I think there's definitely a great need The ED Stop Suicide Collaborative next meets this Thursday, August 24th. And some of the PMHCA programs that have been already trying to expand their work in the ED space will be sharing a little bit about that work, what they're doing, and how they're helping to support these ED teams so that we can develop better strategies and partnerships. So we're looking forward to that on August 24th.
My understanding is there was a pilot project this last year that struggled to get into the ED departments, and I think we have to look at different approaches. And I don't know enough about what was tried, but I just know that there was some resistance.
Yeah, and I'm not sure how much was a misunderstanding versus miscommunication around that, but the goal for PMHCA awardees was never to try to force direct integration into the ED and providing care directly there, but to figure out the ways to help support EDs more broadly, whether that be on the front end around how schools, primary care physicians, families are deciding when to come to the ED, how to inform them on what to expect, having an awareness of how EDs are struggling, maybe a way to provide teleconsultation services if that's the interest or within the available resources of the PMHCA program, or as some have done on the back end of after a child is discharged, how do we integrate them into mental health resources within the community? So the intent was never to say you must integrate into ED care or develop immediate direct teleconsultation or telemedicine services. So it might have been a misunderstanding or a miscommunication. But this is more kind of exploratory based on the skill sets, resources, and the needs, if that answers your question.
Yeah, that makes sense. And I do think there's definitely different approaches and many different needs. So there's definitely other ways to look at it. So I'm not sure which way we'll go, but I appreciate learning a lot today just because I feel like I'm on step one. So
Yeah, no, that's great. I mean, hopefully, well, you will hear that each of the programs that's been engaged in this work, the PMHCA awardees that have been engaged with us so far, have developed very different approaches, and some are much more advanced in kind of their work, and others are just beginning to think about it, and all are welcome. So the goal is not to dictate or define success.
And I can show real briefly one of the slides again, just kind of highlighting where a lot of our teams are. Some are at the very beginning of just conducting needs assessments all the way to, they're piloting their teleconsultation line. So variable, but all useful.
Yeah. So needs assessment, just kind of understanding the landscape to actually engaging directly within. So, but a lot of working on educational opportunities for providers, and Heidi, given your background in education, that might be a nice entree for you guys. So. We don't have to stay on for the full hour. I know we're closing in on the hour, but Heidi, are there any questions that you hoped we might answer that we didn't, or any thoughts you had that you wanted addressed?
no, not right now. I feel like I have to go back and see what we've done and chat with the current staff to see what we're looking at for this next round. So
Yeah, sounds good. And again, if you're interested, you might think about reaching out to Erica Kane, who's the MSC State Partnership Manager in Wisconsin. And
she's moved up on my list.
yeah. She'll have some great ideas. I mean, you can just tell her you're a HRSA awardee and you work on this pediatric mental health, and looking at ways that you might support emergency care systems that are struggling through education or otherwise, and she might have some great ideas and connections for you. So. All right, Jen, is there anything else you felt like we needed to cover today?
No, I don't think so, but Heidi would love to keep in touch with you to see how things go. And again, we look to continue to offer continual technical assistance, and love to touch base with teams who are looking at expanding their services into the emergency care setting. So as you're going through things, we'd love to be in contact with you just to see how things are going.
Sounds great. Thank you.
Awesome.
All right. Well, I think we
Great.
can stop recording and wrap it up. Thanks for joining today.